A 16-year-old boy. A 16-year-old boy is brought to the office. A 16-year-old boy is brought to the office of a 1-month history of intermittent sharp pain of his ring and intermittent sharp pain of his ring and small finger of his right hand. Ring and small finger of his right hand. He does not recall any trauma to the hand, has not had fever, weakness, chills, rash. He has no history of serious illness and takes no medication. He is right hand dominant. He plays varsity football and pitches the varsity football team. Oh, varsity baseball team. He's a pitcher. Okay. He has a first time. Sorry, he has a part-time after school job bagging groceries a local store. His mother has moderately severe rheumatoid arthritis. The patient's vital signs are within normal limits. Both wrists and hands are normal. Muscle strength is 5/5 in upper extremity. Range of motion of the shoulder, elbow, wrist, finger joints are full bilateral. Which of the following is the most likely cause of this patient's pain? Ready?
No, one moment.
It is not osteoarthritis. This is not the age. And synovial crystal depositions in gout and pseudogout, isn't it? Crystal arthropathy.
Activity,
Also in maybe sport.
groceries, bringing groceries. Okay.
I think that it is compression of the ulnar nerve, isn't it?
Oh,
Because uh, small
oh.
finger and
Mm-hmm.
ring finger
Mm-hmm.
goes with the ulnar nerve.
Mm-hmm. Okay.
So
Let's see.
is it Guyon canal?
Um,
But it is ulnar nerve, isn't it?
yeah, we know it's ulnar nerve, but that's not the question is asking what's causing the compression of the ulnar nerve. That's kind of the
He
question.
is a pitcher like
Uh-huh.
who is a basketball baseball pitcher means who throws the ball, isn't it? In our country, baseball is not played, so
Yeah,
we
I
don't
don't I
know.
don't know. I don't know
But
how
in the USA, it is very popular game. You haven't,
yeah, I've been here for so long, but I never knew how to.
you
I've
are
never
not interested in any sports.
no, I am. I like tennis and I like what is it? Not football, soccer. The one with the feet.
J- Uh, okay,
Yes. Yeah, but baseball I've
for
never
girl, okay, don't take it in a bad manner. Whenever
what
I think about like in the girl, like uh, most of them, if they are not like they if they do not want to play something, they become the like in the basketball there are okay, stop it.
oh,
Let's
okay, what are you trying to say? I don't
no, like most of them becomes the cheerleader. Why is that?
ah! That is funny.
Truly, like in the sports, the uh, like I in our country baseball is not popular. In our country cricket is popular, but
Yeah, yeah.
I in our school like basketball, this type of thing is played. Like
Mhm.
basketball is very popular in
Yeah.
our school. And in the USA, like the one of the some richest people came from the basketball, like NBA player. You heard about the NBA
Yeah.
player? Okay,
Yes, MBA. Mm-hmm.
NBA, like they are very rich. like
Yeah.
more rich than even the doctors at the.
Yes.
Yes,
Yeah.
because
Here.
that sports is very popular, and
Yeah.
in that sports, like before starting the sports, this thing, like they came. Okay,
Yeah. No, here, yeah, baseball is popular. I just never been able to learn the rules. I don't understand the rules. So I got tired and I was like, yeah, fine. I'm not even gonna
so
try.
you have never tried in your school or in your college, like you.
No,
Okay,
no, I don't
okay,
know. I just,
okay. You are not enthusiastic
medical
in.
school don't, we don't have time when, you're gonna go to
No, no,
medical school, then
no.
time to
In
do all.
medical school, like what they are doing, just do one shot, like your
Mm-hmm.
interest. Because I have done plenty of sports like chess, table tennis. I have done lots of things.
No,
What?
in
Yeah.
high school, I mostly did soccer and basketball. So
Okay.
I didn't do that. Yeah, it wasn't. Yeah,
Because
that's
you
not.
sports is like sports is good actually. It is good for health. It is good for actually. It creates enthusiasm. Okay.
Yeah, it is. It is. Oh, like a lot of people reply to my. Now I'm even more confused by what I put by my question
Like
that they
what they are saying. What?
because everybody's coming with like a different thing. Like this
Yes,
guy
that is
said,
a problem. That is a
like
problem.
now I'm like even more confused because yesterday I told you the guy says similar to free 120 and NBME 14 and 15.
Okay.
Then
One thing
somebody else.
I haven't told you yesterday. Sorry for interruption.
Mm-hmm.
The person who said this, he got 2 to 5 question from these two NBME. Do you think that
Problem.
5 question is the exam?
No, but my question was like the length.
Uh,
I
uh,
wasn't even talking about the question.
he actually ignored everything. Uh, if you ask 100 people has 100 uh, different views. Because in the exam, what happens? We actually forgot we actually forgot what we have done good, but we do not see the whole exam in that manner, that what I am observing. They actually remember what they are good at, what they are bad at. Some people say the good observation, some people say the bad observation, so you do
Mm-hmm.
not get the total observation.
Mm-hmm.
So if you like, what have you heard from your post? Then I can make an assumption. Okay, say
Jesus Christ. The first person say, yeah, what I told you. The
yes.
second person say that 80% is similar to CMS, and then 20% are like, what the fuck? And
Okay,
then, and then the other person saying they're like, um, oh my God, they are similar to the chart-based question or HPI question.
okay.
Like, I don't know if you know those questions where it says patient 24, blah, 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 and it just give you
Oh
like a chart.
yes,
Yeah, they said that this
the
is
big questions
the
in the.
big no,
Yeah.
yeah, yeah. And some person, and then the same person said that is the same concept, but the questions are like the chart based type. Yeah. So it looks like it's long, but it's actually like a short question. And somebody
No,
said,
that those questions are very difficult to find out the answer. We have done plenty of question in the world in this pattern.
yes, yeah, she's saying that this is, but this person is saying that actually you're never gonna be with those child just those child questions. You will know the answer. It's never gonna be like I have two answers that can be the right answer. If you by the end you will know what's the right answer. That's what they're saying. But people get scared because the question looks really long. And then somebody say, I just tested today. I think it was more similar to free 120, but NBME helped. And then somebody say, lengthwise, for the length, they are long, but you can manage to finish the block with 5 minutes remaining at least. So don't worry. Some
it,
people,
yes, it varies from person to person. We are not that
yeah,
kind of person that we
yeah.
left 4 to 5 minutes before the end of the block. I think that I need extra 5 minutes to end the block.
That's why I replied to them like this is probably not gonna be me because I always run out of time. And then somebody say I recently took it and it was nothing like the MBA means. Most of them had super long stems. Like I got to scroll twice to get to the option, but somebody said it correctly. Read the last line, and then the next person say, "I guys, I just got
Just
my
reading the last line, you will not gonna get the answer.
oh
Yes,
my," and
that is wrong.
the other person was like, I just got my step two scores results and all my MBA means were 250s. And then now I got 227. So what do you advise me? And then the last comment was super long. That had to, it's like super long advice. It says one, always read the last line first of the question, then go to the exam findings. No, then read the options and then find the clues in the question, especially the
Like I do, but this is a wrong
yeah,
way of interrupt. I actually do that. I know, and lots of time I do mistakes. And
yeah,
one of my colleague says that if you do it in that way, that you read the last line and you start looking for the clues, it will not gonna help because
I
what
don't even look. I don't know the whole clue thing. Like I read the last line, but then I read the whole the question itself. The whole looking for how you look for clues
like
in a question that you never seen before.
what I like the way you read, that you read everything. That is good. That is very good. Because if you read everything, all the you will get all the ideas of that question. Like suppose suppose a question comes with like gastric cancer, but they are talking like yesterday the last question of the yesterday, think about, the question
Mm-hmm.
was very similar to pyloric stenosis, but
Mm-hmm.
we actually ignored the
Mm-hmm.
time frame.
Mm-hmm.
But the last question actually make us conscious that time frame is important. We are actually ignoring the time frame. We are
Mm-hmm.
actually very busy with the projectile vomiting, not bilious, these and that. You got my point.
Yeah.
Every word tells a story. Actually everything tells
Yeah.
a story, and you need to fix all the dots and make it correct.
Yeah.
So your way of reading, like reading the whole question, is wonderful. Not look, I know, I actually do. I actually see the last line. Even if we started, like initially, I do not read the question. You are reading the question. I am reading the options. So sometimes I do it very fast because I know the clues. So
Mhm.
I am doing it very fast. But this is a wrong way of doing question. Even if you know the answer after getting the clue, you should read everything because some clue may change the answer. You got my point. So
Yeah.
that idea actually excludes. And the other idea, like
Oh, I
there,
sent you
yes,
the last
I have
comment.
seen.
When you do it, you
So
say, yeah. He's
so
saying that last line thing is mostly for the HPI questions, since I guess there's a lot of them. Yeah, he said for those questions, just do it like that. And then second, I think he means what you told me about the images, just
yes,
for them to look at the image.
in
Hmm.
derm, in neurology,
Yeah,
and in cardiology,
yeah,
if you become the master of the uh, picture, that would
yeah,
be correct. Like
yeah. That's what he said.
if you interpret the tinea, if you interpret the candidal
Yeah,
intertrigo, because
yeah,
like any picture from candidal intertrigo I can manage, like I can visualize those picture. You got my point. So
mm-hmm, mm-hmm.
you need to see uh, again and again to make it as a habit that
Yeah,
this is the
yeah,
thing and this is the answer.
yeah.
On
So
those
it was
questions you do not need to read the whole stem.
Yeah, that's what he's saying in point two. I think point three he's saying for biostat, just click something and move on. Don't waste time. You can come back after.
Do
And
you
then he said
do you think that it will gonna correct the bias stat? You you
basically
you are
if
very
you are
good at bias stat.
if
You
you are not seems like if you're not good, just click something and move
So
on.
if we like if you start giving exam in that manner, I can do 40 question with 30 minutes.
With 30 minutes.
Yes, because I don't need to think anything.
Yeah.
I just need to see and pick.
Yeah, no, but he said for biostat, like if you are like so bad in
There
biostat,
are
don't you know.
5 to 6 biostat question in each block. What you will do? Why I am emphasizing the biostat? That's why. Like 5 question from biostat to you you need to prepare for every block in that manner. 5 question from biostat, 2 question, 2 or 3 question maybe long question, the very big question, and 1 to 3 question maybe out of your reach. So you have to uh, you have to leave the 10 question, then you have to fight for the next 30 question. Are you, yeah, strong enough to fight that 30 question?
Yeah.
Do you think that you will able to correct those 30 question, 30 out of 30? Is it possible? I don't think so.
Yeah.
So you, like, I think that we should as we are preparing, we should hope for the very bad, very least.
Yeah.
We have,
Yeah, but because
because
what I
if
deduced
we
from
become happy that oh, NBME and CMS is all about, then
hmm
you will get a shock in the exam.
definitely from all these comments, I deduced that everybody has they all had like different forms.
Yes, all have
Yeah,
different
they all
views.
had different forms, and so some of them were long, some of them had a lot of HPI, some of them
Yes.
had yeah.
So
So
you got the point. Like,
yeah,
it's your luck that what
yeah,
form you will get. If it is a very good form like based on cardiology, rheumatology, neurology, then it would be easier for you.
mm-hmm.
So I think that we should not think on that way. We should keep our focus what we are doing. But
Yeah,
one thing we need to do, we need to, like, that, like a question, you know the answer, but even if you know the answer, you are making mistakes. It will happen because
yeah.
that the confusion we need to clear. There are some 2 by 2 confusion. Uh, so we need to fight out those confusions.
Mm. Oh my God. Okay. But yeah,
Just
I'm not asking I'm
just
not asking any more questions.
don't ask to anybody,
Yeah, I'm
because
not asking.
everybody has like you will get in another 100 answer if you ask people.
Yeah, because everybody has a different like yeah opinion. Okay. Ulnar tunnel syndrome and cubital tunnel syndrome. Neuropathy of the ulnar nerve occurring at the level of the elbow. The ulnar nerve innervates the intrinsic muscle of the hand like lumbricals, interossei, hypothenar and palmaris brevis, and muscles of the forearm like flexor carpi ulnaris and ulnar portion of the flexor digitorum profonus. The ulnar nerve also provides sensation to the volar aspect of the ring and small finger. Patients with ulnar tunnel syndrome most commonly present with sensory symptoms, with more severe cases presenting with hand intrinsic muscle weakness or claw hand deformity in this case. The patient was most likely to develop ulnar neuropathy at the elbow from repetitive pitching. Other risk factors include prolonged leaning on elbows, repetitive forearm pronation and supination, or activities that require repetitive grip. Diagnosis can be confirmed with electromyography and nerve conduction studies. Treatment is conservative with surgery reserved for refractory cases. It's not occupational tasks that include repetitive grip or pronation, supination activities can be a risk factor for developing ulnar tunnel syndrome. This patient is like 16. With a part-time job bagging groceries, because of the part-time nature of the job, his position as a teacher is more likely to cause the pain. Okay, next.
6 hours after a 10-year-old boy undergoes operative repair of a humerus fracture, his parents notice that he is unresponsive and barely breathing and notify the nursing staff. The patient has no history of serious illness. His only medication is IV morphine. On evaluation, he is conscious. His temperature is 37 degrees Celsius, pulse 120 per minute, respiration 10 per minute, blood pressure 90 by 50, pulse oximetry on room air, oxygen saturation is 88%. The pupils are 2 millimeter. The remainder of the examination show no abnormality. IV naloxone is administered and the patient regains consciousness. The respiration is 18 per minute. It is the most appropriate for the hospital to investigate this incident as which of the following.
This one has an answer. Ready?
Okay, ready.
Okay. So a sentinel event. This patient received too much of the medication,
You got
resulting.
correct?
Yeah, you cannot see my screen.
Yes, I can.
Okay. This patient received too much opioid medication, resulting in decreased consciousness and life-threatening respiratory suppression. This incident can be defined as sentinel event. Patient safety event resulting in death, permanent um, harm, or temporary serious harm that may require life-sustaining treatment like naloxone. Sentinel events typically prompt a root cause analysis to determine the factors contributing to the adverse event. RCA, so root cause analysis, involves determining the core system level issues that led to the chain of reaction of events that culminated in the adverse event. There are several RCF strategies, including creating a timeline, surveying the controls in place that may have failed, and completing a risk tree analysis where the impact of each event is considered. Multidisciplinary team commonly works to define and analyze the problem and design a set of corrective actions based on the analysis. It is not act of negligence, refers to a failure to act the way a prudent physician would under similar circumstances. In this case, no individual is identified as culpable, but the principle of SES system level causes like lack of standardized opioid, blah, 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 rather than individual levels causes at the root of most adverse event. And it's not perioperative risk, refers to the risk for perioperative adverse patient safety events. This implies hypothetical event. The case describes the occurrence of a real event, not a hypothetical event. Adverse events related to opioids are rare if treated. What is perioperative means before the operation or after the operation again?
Perioperative means during the operation.
During
Preoperative is before the operation. Preoperative.
perioperative during the operation. Okay. Got it.
Next,
Okay.
an 82-year-old man comes to the physician because of 8-month history of progressive urinary frequency and decreased urine stream. He underwent transurethral dissection of the prostate 11 years ago because of benign hyperplasia. He takes no medication. Examination shows moderately enlarged prostate. His creatinine is 1.3 10 months ago to 2.4 today. Which of the following is the most appropriate initial step in management?
Hmm. Ready?
Mm, yes.
So it is measurement of post-void residual volume. BPH affects middle-aged and elderly men patients and occurs as a result of excess growth of tissue in the central zone of the prostate,
Retrograde
causing
urethrophy for urethral injury, isn't it? Like
yes,
stratal injury.
yes, causing lower urinary tract obstruction. BPH presents with urinary dribbling and incontinence, difficult starting or maintaining urinary stream, nocturia, and the need for frequently urinate and incomplete voiding. These symptoms are typically insidious, in onset, chronic, and progressive. Chronic outlet obstruction leads to urinary retention and may cause the formation of bladder diverticula or lead to hydronephrosis. Patients with urinary retention may develop urinary UTI due to loss of hydrodynamic flushing of bacteria out of the urethra, or AKI due to urinary outlet obstruction. This patient acute AKI, as evidenced by increased creatinine, is likely caused by urinary outlet obstruction secondary to BPH. Diagnosis is made by history, physical exam, urodynamic testing, along with ruling out alternate diagnosis like prostatic cancer. The first step in diagnosis of urinary outlet obstruction is measurement of post-void residual volume. Treatment is with supportive care, alpha blockers, example tamsulosin and finasteride or surgery. It's not urine cytology showing malignant cell is highly specific for bladder cancer, though this finding is not always present. Cytoscopy is the gold standard for diagnosis of bladder cancer. This patient does not have any hematuria that suggests bladder cancer, and urinary outlet obstruction is most likely BPH. And it's not, that was E. CT scan of the abdomen may help diagnose other causes of urinary outlet obstruction, such as nephrolithiasis and intra-abdominal tumors. This patient does not have any flank pain that would suggest renal stones and chronic abdominal pain that would suggest intra-abdominal tumor. He has a history of BPH, which is the likely cause. Okay, next.
Next. A and which of the following is the most appropriate next step? An 18-year-old woman comes to the office for a routine examination. She has osteoarthritis, hypertension, peptic ulcer disease. Her medications are acetaminophen, lisinopril, omeprazole, omeprazole. She says that she has joint pain and stiffness. She has joint pain and stiffness which limit her mobility and make it difficult to her to open her medication bottle, shop for groceries, cook and clean. She lives alone. Vital signs are within normal limit. Examination shows bony enlargement of the shoulder, joints, hands and neck. There is bony enlargement. There is crepitus. Range of motion is limited by joint tendon. Which of the following is the most appropriate next step in the management?
Hmm, I don't know. Ready?
Yes.
Okay. This multidisciplinary geriatrics assessment. Frailty is commonly encountered in older patients as a result of a variety of factors and presents with multiple problems across medical, functional, and social domains. In this scenario, this old patient who lives alone presents with several medical comorbidities that have resulted in difficulty performing activities of daily living. Multidisciplinary geriatrics assessment involves an evaluation by a team of several different specialists and may include physicians, occupational and physical therapy, social workers, and home health nurses and aides. Multidisciplinary assessment can help to identify the patient needs and goals and address medical, physical, and social challenges while coordinating an overall plan to meet these goals and to regularly assess progress. The patient in this scenario may benefit from pharmacologic and non-pharmacologic treatment of for osteoarthritis, physical therapy to improve mobility, assessment of home health nurse to improve her ability to function independently, as well as social work assessment to ensure that she has adequate social support. It's not give steroids. Intra Giftero is an appropriate choice for treatment of theater, particularly of the knee and hip that is refractory to more conservative treatment with exercise and topical and oral NSAIDs. This patient osteoarthritis affects a lot of joints and has led to multiple problems with activities of daily living, including opening bottles, cooking, injection of steroids alone is both premature at this time and also unlikely to address all of her functional difficulties with activities of daily living, and is not placement into a nursing care. Is premature at this time. A multidisciplinary geriatrics assessment should first be performed to assess the patient goals and priorities in order to provide patient-centered care. If living independently is a priority, an assessment may be able to help her meet the goal and continue to live independently. Placement in a nursing home may be considered if those measures fail or if the patient no longer wishes to live independently. Next.
Next. A 32-year-old woman comes to the physician because of 6 week history of mild headache and fatigue. He has no history of serious illness, takes no medication, he does not smoke cigarettes. He drinks 2 to 3 beers nightly. 4 months ago, he began a high stressful new job in which he has a verbally abusive boss. He says he says he has financial concern and is worried about job security. He used to exercise 3 times weekly but stopped exercising 3 months ago because he's too busy. He lives alone, in not in a romantic relationship. He appears tired and withdrawn and responds to question with short phrases. Which of the following is the most likely diagnosis?
There's fatigue. Mm, just for
Yes. Stress,
uh,
lives alone, depressed, tired, interest fatigue.
ready.
Are you thinking about MDD?
Thinking about I'm between NDD, alcohol, and generalized.
Excessive worrying. Where is the worry?
But alcohol doesn't make that much sense. You should have more like issues.
Drawn, responsible.
But generalized, he has worried about financial, about job security. Yeah, I guess that would be the only two worries.
Okay.
Okay. So yes, MDD. This patient demonstrates signs of MDD, including decreased mood, fatigue, decreased motivation, indicated by social withdrawal, Symptoms of LDD include 2 or more weeks of depressed mood, anhedonia, guilt, wordlessness, difficulty concentrating, suicidal thought, decreased energy, sleep disturbance, appetite disturbance. By definition, this system disrupt everyday function, decrease self-care in the form of exercise. MDD commonly arises from a combination of genetic vulnerability and stressful life events. As seen with this patient, whereas many women with MDD present with sadness, men may not present with sadness, but may present with irritability, decreased interest in work, and fatigue, depression. In men, also commonly presents with somatic symptoms. MDD and somatic symptoms, especially pain symptoms, occur together, which is postulated to arise from common descending pathway. MDD is commonly treated with antidepressant and psychotherapy. It's not Alcohol use is a clinical diagnosis made by presence of personal, professional, social, emotional, behavioral, and physical disturbance related to the use of alcohol or attempts to quit. This patient drinks slightly more than recommended, which is likely an attempt to cope with MDD. However, his daily dysfunction is not related to excessive alcohol use or attempts to obtain more alcohol. Given his social withdrawal and pervasive fatigue, his dysfunction is likely MDD. It's not generalized anxiety. It's an anxiety disorder that features excessive worry about a range of topics with associated functional impairment that lasts 6 months. So, yeah, this patient worries and are specific to his work situation. Yeah, so it's only 6 weeks. Okay, next.
Okay. A 19-year-old woman comes to the office because of 1 month history. Because of
Wait,
one,
where are
sorry.
you reading?
Question
Nine.
7. Oh, sorry.
Oh, 6.
I skipped 6. Sorry. Which of the following is the most appropriate next step in the management? A 55-year-old woman comes to the office as a new patient comes to the office as a new patient because she was dissatisfied with her last physician. 4 months ago, 4 months ago she had the onset of moderate chest pain. 4 months ago, she had the onset of moderate chest pain. Cardiac stress scintigraphy showed a small area of reversible ischemia. The patient was diagnosed with stable angina after beginning. Patient was diagnosed with stable angina after beginning with metoprolol therapy. Her chest pain decreased from twice to once weekly. She has no other history of serious illness, takes no medication. Her temperature is 98, pulse 62, respiration 16 per minute, blood pressure 115 by 70. Examination shows no abnormality. Our previous physician recommended that she undergoes cardiac catheterization, but she declined after researching the procedure on the internet. She says she has read the medication alone is acceptable alternative to cardiac catheterization, and that she is unwilling to accept the risk associated with the procedure. She agrees to add atorvastatin to his medication regimen. Which of the following is the next step?
Ready?
Yes.
So it is no further management indicated at this time. This patient with stable angina that improved with medical therapy and cardiac stress test demonstrating a small area of reversible ischemia does not warrant any further diagnostic testing at this time. The primary indications for cardiac catheter in patients with stable angina include angina that is severe, and interface with patients' daily living or stress test that indicates a large area of affected and viable myocardium. Patients with mild stable angina, such as this patient, initial medical management is appropriate, and beta blockers agents are recommended as first line therapy. Beta blocker agents reduce both pulse and cardiac contractility, thereby reducing cardiac oxygen demand. Um, and improving angina symptoms. Additionally, all patients with stable angina should be started on statin, an antiplatelet agent to reduce risk for disease progression and further adverse cardiac events. Further, this patient appears to have received appropriate counseling about the catheterization and appears to have a throughout stable understanding of the risks and benefits associated with the procedure. Given appropriate counseling and decision-making capacity, her choice should be both documented and respected. And it's not B, referral to cardiologist is not currently necessary. This patient has refused cardiac catheter. If her disease progresses to the point that cardiac catheterization is needed, cardiologist control will be warranted. Okay, next.
A 19-year-old woman comes to the office one month history because of 1 month history of persistent nausea and feeling hot when others do not. During the first year, she has 4.5 kg weight gain her despite no changes in the appetite. Her weight is unchanged since last visit 1 month ago. Minerva was 13. Since then, have occurred irregular 24 to 42-day intervals with varying amount of flow. Her menstrual cycle, her menstrual period was 3 weeks ago and was much lighter than she expected. She is sexually active with one partner. They use condom inconsistently. She is 168 centimeter, 5 feet 6 inch, and weight is 77 kg. BMI is 27 kg. Vital signs are within normal. Examination shows no abnormal. Which of the following is the most likely to confirm the diagnosis? Is it thyroid disorder?
I don't think so, but
Ready?
yeah. So is measurement of urine beta ICJ concentration. Clinicians should maintain a low threshold of suspicion of pregnancy in reproductive age patients presenting with changes in the menstrual cycle, especially when those patients use contraception inconsistently. Early symptoms of pregnancy, in addition to regular menstruation, include fatigue, nausea, breast tenderness, urinary infrequency. While amenorrhea is a more common sign of early pregnancy, live vaginal bleeding can occur with the implantation of a fertilized ovum and can be misinterpreted by menses. Evaluation of this patient include measurement of beta HCG concentration in urine or serum, with the concentration being um, increased in pregnant patients. Transvaginal ultrasound can be used to confirm the diagnosis. The most appropriate test to confirm the diagnosis in this patient presenting with nausea and changes in menses is through urine beta ECG. Measurement of free thyroxine concentration in TSH may be used in the diagnosis of hypo or hyperthyroidism. In primary hypothyroidism, the thyroxine concentration is decreased, whereas TSH is high. These concentrations are reversed in primary hyperthyroidism. Hypothyroidism presents with weight gain, lethargy, fatigue, constipation, hair loss, cold intolerance. In contrast, hyper presents with heat intolerance, hot flashes, palpitation, weight loss, diaphoresis, and diarrhea. Both conditions can cause oligo or amenorrhea. However, ruling out pregnancy with beta ECG concentration should be done before pursuing other causes. Next.
Next, the 45-year-old man was diagnosed with type 2 diabetes is diagnosed with type 2 diabetes mellitus 5 years ago. The office for a routine follow-up visit. Her diabetes has been fairly well controlled with metformin. At last visit 3 months ago, his A1C hemoglobin A1C was 7.8. His metformin increased to 750 milligram twice daily or 1000 milligram daily. She also takes glipizide and atorvastatin. Lab studies include complete metabolic count, serum lipid profile, screen for the microalbumin during the previous 3 months ago were all in the reference range. In addition to measuring the patient's hemoglobin A1C, which of the following is the most appropriate step in the evaluation of today's visit? He came that is long, 3 months ago.
Ready?
Yes.
So it's an examination of the patient fit. USPSD recommends various screening tests and intervention for patients with type 2 diabetes. Adults with type 2 diabetes should be screened for high blood pressure at every medical visit. Lipid profile screening should be done at least every 5 years to measure cholesterol, LDL, cholesterol, HDL, cholesterol, and tags. So at least every 5 years, once every 5 years. Annual urine albumin to creatinine ratio test and blood tests to measure creatinine should be performed to detect early stage kidney disease. So once a year. Comprehensive eye exam, foot exam, depression, weight management, tobacco cessation are recommended every year. Um, However, guidelines may need to be individualized based on the patient's specific clinical characteristic and comorbidity. Given that this patient has had all the above studies except for the exam at the 3 months prior, this is the most appropriate exam. Okay, so everything is annually except the lipid profile that's done every 5 years. Okay,
Okay,
next.
next. A 15-month-old girl is brought to the physician by her mother because of 5-day history of fever, sleeping, and decreased appetite and fuzziness. She has no history of serious illness and known allergy. She received no medication. She appears mildly ill but interactive. She is at 75 percentile for length, 50 percentile for weight. Temperature is 101 degree Fahrenheit. Examination show purulent and nasal discharge. The tympanic membrane is edematous and erythematous. Tympanic membrane and oropharynx are normal. Which of the following is the most appropriate pharmacotherapy?
Has a Proctitis media. So is it macrolide or ceftriaxone?
Ceftriaxone is not. So, what is your
Otitis.
diagnosis?
He has otitis media.
Otitis media is amoxicillin, isn't it?
Oh,
If second line is amoxicillin clavulanic acid, he is not penicillin allergic, isn't it?
he's not penicillin allergy, no. Okay, so it's amoxicillin. Okay, let's check.
Probably
Yeah,
And
you're right. Amoxicillin. Acute otitis media is an acute infection of the middle ear, usually spreads to this space via the eustachian tube from the nasopharynx. The middle ear is bounded externally by the tympanic membrane and internally by the oval window. Eustachian tube connects the middle ear to the posterior nasopharynx near the ear. Acute otitis media classically occurs in infants and children, often from viral or bacterial pathogen, commonly strep pneumo and Haemophilus influenza. It presents with ear pain, often with fever and erythematous tympanic membrane with retrotympanic pus and middle ear effusion. Infants may present with non-specific signs of fussiness, decreased appetite, poor sleeping, as well as ear tugging. Recurrent inpatient may lead to mastoiditis or scarring of the tympanic membrane with associated conductive hearing loss. First line therapy, amoxicillin with or without carbolonate, as well as symptomatic treatment. Amoxicillin is beta-lactam antibiotic with broad spectrum against gram-positive and gram-negative bacteria, including strep and hemophilus. It is commonly used to treat pediatric upper respiratory tract sinus ear infections. It's not azithromycin macrolide antibiotic that binds to the bacterial ribosomal 50 sobrinin is commonly used to sinusitis, pharyngitis, respiratory STI. Um, it has limited activity against organisms that commonly cause acute otitis media, including strep and hemophilus. Azithromycin is less effective than amoxicillin for treatment of acute otitis media. Cefuroxime, second generation cephalosporin that inhibits bacterial wall synthesis and is commonly used to treat upper respiratory tract infections, sinus and ear infection in children. Cefuroxime has comparable but slightly reduced efficacy against strep and influenza compared to amoxicillin. Cefuroxime is an acceptable alternative and may be used for treatment of acute otitis media in patients allergic to penicillin. Okay, that's crazy because here strep pneumo in sketchy it's not even penicillin that they use. It's like microlides and ceftriaxone, but they
yes,
just keep
that's
it.
why I told you not to follow
Yeah,
the pharmacology from the sketch.
I don't follow. It just comes to my mind. I don't follow it on purpose. It just comes to my mind. Yeah. Oh no, no, it says it here. Treatment macrolides for pneumonia, ceftriaxone or whatever for meningitis. Vancomycin is added if penicillin resistant, and amoxicillin and erythromycin for otitis media and sinusitis. Okay, okay, sorry, you didn't just okay, okay, got it.
Okay.
Next.
A 13-year-old boy is brought to the office by his mother for a well child examination. He has no history of serious illness, takes no medication, growth and development has been normal. His medical records indicate the vaccinations were up to date. They are up to date through the age 9 years. He has not received any vaccination since that time. Vital signs are within normal limit. Physical examination shows no abnormality. Administration of which of the following vaccines is most appropriate in this time?
Oh, I hate those vaccine questions, Jesus.
He has not received any vaccination uh, from 9 years, isn't it?
Yeah, between pneumococcal and varicella. Pneumococcal is usually strep pneumo.
Strep pneumonia, if it is sickle cell or other,
Yeah, doesn't make sense.
he has not any serious illness.
Yeah. Mm, okay, pick one. I'm not gonna get this one right. I already know that.
Okay.
Swear these vaccine questions. It was meningitis. Neisseria meningitis. This patient will benefit from vaccination with meningococcal vaccine, protecting him against Neisseria meningitis, which may lead to life-threatening meningitis or sepsis. Meningococcal disease is more prevalent in low and middle income countries, but it may occur in the US in crowded conditions such as dormitory, barracks, or prison. Meningococcal vaccine is available as a conjugate vaccine or as a recombinant protein serogroup B vaccine. The conjugate vaccine is indicated for all children and is administered in two doses. The first at age 11 to 12 years, and the second at age 16. Hmm. Serogroup B vaccine is given as an antidote dose, additional dose, usually between 16 to 18 years, particularly in those who plan to attend an institution of higher education or live in the military. Certain teenage patients are particularly at risk for infection with Neisseria or encapsulated organisms, such as patients with asplenia and complement deficiency should receive vaccine with serogroup B, regardless of the plan to attend college or not. So basically, once you start high school and once you finish college, finish high school, kind of thing. Okay. And then inactivated. Okay, let me read all the other ones at this point.
Yes.
Vaccine, Hep B vaccine is a recombinant vaccine that prevents infection with Hep B virus. Typically administered in three doses. The first given the first 24 hours of life, we know that, followed by second at 1 to 2 months, and the third dose at age 6 to 15 months. So at birth, at 2 months, and again around 1 year, this patient has likely received Hep B vaccine. He's 9 years old. Inactivated polio vaccine is indicated for all children for prevention of polio, which can lead to poliomyelitis. Inactivated polio vaccine is given in four doses at age 2, 4, 6, 18 months, and between the ages or wait 2, 4, 6, and then let's say 6 years old. This patient has his vaccines up to 9 years, so therefore does not require additional polio vaccine. Measles MMR vaccine, live attenuated vaccine that is indicated for all children to prevent measles, mumps, rubella. MMR vaccine is given in two doses, one between 12 to 15 months and one between ages 4 to 6 years. So around like 1 year old and 6 years old. Oh, this patient has likely already received it. Then varicella, oh no, pneumococcal, available as either 13 valent or 15 conjugate vaccine, indicated for all children to prevent infection with strep pneumo. It is typically given as four doses at ages 2, 4, 6 months and at 1 year old, I guess, around that. The Most of them are 2, 4, 6 in the 1 year, I guess.
Yes.
The 23 valent polysaccharide vaccine is indicated for adults also over age 65 years old in a patient with high risk conditions such as CKD, liver disease, chronic smoker. So he probably received it. Varicella live attenuated prevents infection with varicella virus, chickenpox, and shingles. Administered in two doses, like 1 year, or between 12 and 15 months for a 1 year old, and then at 6 years old, kind of. This patient has already received it. Whew, okay.
Can we take a break?
Yeah, let's take a
Okay.
break, please.
Have you done your breakfast?
I'm not probably gonna do it now.
Okay.
Green?
Mm, yes, now.
Okay.
A 42-year-old a 42-year-old man comes to the physician for a routine life insurance examination. He feels well. He has smoked one pack of cigarette daily for 25 years and drinks 2 to 4 alcoholic beverages daily. He works as a journalist sometimes takes him to the developing countries, but he has not traveled abroad during the past year. He has not had any immunization during adulthood except for tetanus toxoid 12 years ago. He has never had blood transfusion. Examination shows no abnormalities. Lab studies show hemoglobin 16.2, hemoglobin 16.2, serum albumin 3.8, total bilirubin 1.1, ALP 95, AST 68, ALT 44, ferritin 50. Which of the following is the most likely to have prevented these lab abnormality?
Ferritin.
What's his problem?
ASTLT and bilirubin are high. Um,
Slightly high. That
yeah. I was think hemoglobin is normal. Let me put it.
hemoglobin is normal.
It's normal. This abnormal. So what would have prevented the, I guess, the liver and the bilirubin?
Is it alcohol?
Administration and data, PEP-A, branch amino acid. I don't know what this means. Phlebotomy. Yeah, I guess abstinence is the only thing that makes sense. Ready?
Yes.
Okay. So is abstinence for alcohol. Increased liver enzymes are often identified in asymptomatic patients. This increase in liver enzymes can be classified into different patterns. A hepatocellular pattern is when there is a greater increase in aminotransferase compared to alphos. Cholestatic pattern is when there is a greater increase in alphos compared to aminotransferase. An isolated hyperbilirubinemia pattern is when the bilirubin is increased while bilirubin increase while aminotransferase and alphos are within the reference ranges. Identifying the pattern and degree of increase of liver enzyme may be helpful in developing a differential diagnosis. When the increase of AST and ALT in a ratio of 2, 1 or greater, yeah, alcohol-related liver disease may be likely. In this case, develop of mild increased AST and ALT with alphos and total bilirubin, alphos is normal, total bilirubin within the difference range. Abstinence from alcohol would likely have prevented the identified lab abnormality.
Okay. Next. An
Okay.
asymptom an asymptomatic 27-year-old woman comes for a routine health maintenance examination. She works as a lawyer. Her temperature is 37.2, pulse 96, respiration 16, permanent blood pressure 144 by 82. Serum studies show thyroxine T4 concentration is 14, T3 is 250, TSH concentration is zero point 0.1. A radioactive thyroid scan show increased uptake and diffusely enlarged gland. Which of the following is most likely cause?
T4 is high,
Source of
T3
hypothyroid, no tenderness, isn't it?
high, uh-uh. And TSH is no. Blah blah blah. Diffusely enlarged, increase uptake. There is reduced hypothyroidism, exogenous administration of thyroid hormone, subacute thyroiditis, hyperthyroidism, makes sense. Severe thyroid cancer, subacute.
Information.
acute thyroiditis, diffusely enlarged,
diffusely large.
diffusely enlarged, but they would. It cannot be Hashimoto because even if those two are high, there wouldn't be increased uptake. Mm, okay, I'll go with that.
You go with what?
With
Okay,
hyperthyroidism. Sorry.
okay.
Mm, the answer is hyperthyroid grave disease. What they don't just say grave disease? Ah, is the like I knew it was grave, but I was like, are they trying to say hyper? That's why it's
Gra
grave.
in the Graves is there is a triad for Graves disease to happen, ophthalmopathy, hyperthyroidism, and there is another feature. That's why they actually trick.
No, I knew it can only be grave because there is uptake. It cannot. There is nothing else here that can it can be. But I was like, I was looking for the word grave disease. So I was like, okay, anyway. Graves is the most common cause of hyperthyroidism in high research nation and occurs due to presence of thyroid stimulating TSH receptor antibodies. This results in a diffusely enlarged thyroid gland and physical exam, which can cause signs and symptoms of hyperthyroidism like weight loss, insomnia, palpitation, heat intolerance, tremor, diaphoresis, petechial myxedema. Though some patients may be asymptomatic, TSH receptor antibodies also stimulate orbital fibroblasts, can lead to thyroid ophthalmopathy, which is characterized by exophthalmos, lead lag, and strabismus. Thyroid function testing typically shows increased concentration of T2, T4, decreased TSH. Addition testing, TSH stimulating antibodies confirm diagnosis. RYU, nuclear scintigraphy, typically shows diffuse abnormal abnormally increased uptake of thyroid gland without a discrete nodule. Treatment options include antithyroid radioiodine ablation and surgery. It is not, what was I confused? B. Hashimoto. Yeah. Hashimoto is the most common cause of thyroiditis and affects women more than men. When Hashimoto disease commonly results in hypothyroidism in the um, early stage can have a transient hyperthyroid. However, these patients increase diffuse uptake on radioiodine, whatever will not be observed. Increased thyroid hormone release. Okay, we know that. And it's not men, specifically type 2A, 2B are associated with medullary thyroid carcinoma as well as pheochromocytoma. This patient has no nodule, no signs of pheochromocytoma. Yeah, next.
Which of the following modification would be the most beneficial of this patient? A 45-year-old man with type 2 diabetes, mellitus, and hypertension comes to the physician as a new patient. He has no other history of serious illness. He takes metformin and hydrochlorothiazide. He has smoked one pack of cigarettes for 20 years. His blood pressure is 142/82. The remainder of the examination shows no abnormality. Lab studies from 1 month ago show hemoglobin HbA1c 7.8%, serum sodium 142, potassium 4.3, chloride 109, urea nitrogen 14, glucose 135, creatinine 0.7, cholesterol 214. More than one. Okay. HDL, LDL 120 and TG 142. Okay.
Let's see. So HDL is normal. LDL is normal. Tax is normal. Everything is normal. Mm, okay, cessation.
It is that question. Primary prevention.
And then prevastatin therapy to the medication. Thiazide.
Wait,
Metformin. 7 point. No, it's not that one. It's the metformin. Because it's 7 point.
why
It's supposed,
metformin?
supposed to be less than 7.
Oh, metformin for creatinine. In case of metformin, oh, what you are looking for.
Uh,
This is the
I was
primary prevention one. Age more than 40 with diabetes.
age more than 40 with diabetes. Okay,
LDL,
so you took prevastatin.
I am thinking this. Why you choose metformin?
Because I thought metformin, the A1C was supposed to be less than 7.
Yes, it should be less than 7, but not that
Okay.
high.
Okay. I guess it's
Maybe you are
prevastatin.
right, but I think that I
No.
am on the track.
Okay. Oh my God. Oh my, you confused me even more now. Okay,
No,
okay,
no,
okay,
you think maybe there is another answer.
okay. Let me. Oh my God, we were like so wrong with everything. Like anyway,
But my answer fits.
but
Age more
but
than
it makes
40 with
sense.
diabetes.
Yeah, yeah, it makes sense. Smoking is a stronger modified risk factor for coronary artery disease. Okay, we know. The most common cause of mortality in adults, the fact, whatever, study found that smoking is associated with approximately twofold increase in mortality for ischemic heart disease. Smoking is also associated with various cancer, stroke, COPD. Smoking can exacerbate type 2 diabetes. Therefore, for this patient and most patients, smoking cessation is the most beneficial behavior change. Patients should be advised that it's never too late to start smoking, as the increase of cardiovascular risk and other risks associated with smoking begins to decline immediately upon stop smoking. Motivational interview strategy, blah blah blah, and determine the guide to reflect whatever. Okay, it is not C.
See,
Adding prevastatin to the medication regimen will assist in addressing this patient hyperlipidemia. Doesn't really have. Hyperlipidemia is a risk factor for coronary artery disease and stroke, but it's not as strong as a risk factor as smoking. Also, it is not commonly associated with cancer or COPD.
I'm
What
not
does cancer has
satisfied
to
with
do?
this answer.
Yeah, I'm like, what does cancer have to do? They say what would be the most beneficial? I don't know. Increasing the dosage of metformin can assist in the patient management of diabetes. Diabetes risk factor for coronary artery disease and stroke, but is not as strong of a risk factor as smoking. I guess the question was like, what is the most the
Important
risk
risk
factor
factor.
for in this
But
patient?
they have written which of the
Yeah,
following
yeah,
modifications.
yeah, yeah, yeah. Is that the question? What is the most important cardiovascular risk factor in this patient history? I think that's what they. This is a really bad question, like really bad written question. Because if you look at all the cholesterol, everything is normal, but based on what you said, yes, it's 40 with
In the
diabetes.
yes,
you-
primary
you-
prevention ASCVD because
Yeah,
diabetes and
yeah,
hypertension is very
yeah.
important risk factor for stroke and
Yes.
myocardial infarction. Okay, skip it.
Yeah, that's not a good question. Please don't tell me to from the image.
Oh
I
yes,
know you're trying to say
yes.
that. I know it's
Look
but
at
there
the
is
picture and tell me your
I
diagnosis. You can
cannot
diagnose.
but
You
I
wait,
can
wait, wait. Look at the age, 70 years, and this is the humerus, this is the humeral head, and it is almost fixed, and there is sclerosis, whitening area. Now tell me your diagnosis. And there is crepitus. Everything I have told you.
okay, so it's osteoarthritis.
Yes, Mhm.
and that
Okay,
doesn't
now I
happen.
read
And
the question. You have diagnosed right.
okay.
Truly, I am very confident that it is osteoarthritis.
Oh,
A 70, not that confident like previous one. Okay,
that's
a 72-year-old woman comes to the clinic because of 6-year history of increasingly severe pain, progressively decreasing mobility of the left shoulder. She has congestive heart failure, coronary artery disease, kidney disease, type 2 diabetes mellitus. Her medication is metoprolol, enalapril, glipizide. Range of motion shoulder is decreased and can cause crepitus. X-ray of the left shoulder is shown. Which of the following is our next step? Most appropriate. Is it
she has.
physical therapy or ibuprofen?
I don't because she doesn't have pain. Did she say she just have decreased? Oh, she says severe pain.
Isn't it?
No.
Yes, progressive.
Mm. Recommend anti-inflammatory.
I
Ah,
think that uh,
yes. And said no.
ibuprofen.
You cannot give ibuprofen. She has CKD.
Oh,
Yeah. So
then
it's either
celecoxib.
celecoxib or physical therapy. I don't know why I feel like it's physical therapy. Probably celecoxib.
Where is CKD? Celecoxib is COX-2 inhibitor. In
Cox,
in severe pain, what will recommend an anti-inflammatory diet? No,
no.
no.
I don't think it's ibuprofen because she has kidney disease. So it's either celecoxib or physical
Where is
therapy.
kidney disease?
Right here.
Okay, sorry, kidney disease. Okay, so, okay, physical therapy. Let's see.
Yes, yes, physical
Okay,
therapy.
physical therapy.
Osteoarthritis, you were right. Non-inflammatory arthropathy that occurs secondary to deterioration of
Don't
cartilage.
fear to look at the picture.
Bones. It typically occurs in older patients, may affect any joint. The hips and knees are commonly affected because of chronic weight bearing. Um, with the shoulders and hands also being commonly affected. Osteoarthritis is not associated with inflammation or infection and is generally insidious in onset. Patients typically complain of chronic pain in a joint that is worse with movement or exertion and improve with rest. The patients often have limited range of motion by underlying joint space narrowing and pain. Imaging may show joint space narrowing, osteophytes, subchondral cyst, sclerotic
Subchondral
pain.
sclerosis, yes.
Oh,
These four
subchondral.
finding, joint space narrowing, osteophyte, subchondral cyst, and subchondral sclerosis. These four finding is typical for osteoarthritis.
First line treatment is conservative with physical therapy and oral pain medication as needed. Initial pharmaco include acetaminophen, although only a minority of patients will achieve meaningful relief with that one. Additional options NSAID, intraarticular joints of steroids, injection of steroids, and joint replacement surgery for severe refractory cases. In this case, the patient has cardiac and kidney disease, which is a contraindication for NSAIDs, as they have, yeah. The most appropriate next step is physical therapy. Celecoxib and ibuprofen could be reasonable treatment option in addition to physical therapy. For our patients without cardiac or kidney disease, NSAID medication may be useful to decrease pain and allow patients to participate in more fully physical activity. So celecoxib and NSAID kind of have the same. Yeah, yeah. Next.
Yes, okay, next. A 17-year-old boy comes to the physician because of 3-day history of increasingly severe pain in the right testicle. She He has also had sweating, chills, burning pain, and urination during this time. He has no history of severe illness and takes no medication. His heart temperature is 101, and often vital signs are within normal in the examination shows edema and tenderness to palpation behind the right testicle. Which of the following is the most appropriate next step?
Burning pain with urination, antibiotic, one back.
Is it mumps or torsion or
Mm,
tortoise?
3 days, probably not torsion.
Yes, 3 days
Um,
for mumps or epididymitis. There is fever
uh,
also, but
there's
probabil-
fever, so
probability of mumps is much more.
yeah, I'll probably give antibiotics to her because she
In
has
mumps
fever.
is a viral. You are thinking about
Oh,
epididymitis.
sorry. Yeah, that's true. Sorry, sorry. It's probably not. It's probably not moms because it's yeah. But it can be moms. Tenderness and palpation. No, probably not moms. But he has fever, so I'm thinking just give antibiotics. It's either antibiotics or ultrasound of the scrotum.
I
I
don't
think
think
it's.
so. Okay, next, let's see.
Let's see. Yeah, it's
Yes, you
antibiotic.
are right. We are epididymitis. It is epididymitis.
Oh,
I am
patient has a
stay. Yes,
presentation consistent with epididymitis, and the most appropriate next step is antibiotic therapy. Acute epididymitis or infection of the epidermis most commonly presents with unilateral scrotal pain associated with tender swollen mass over the posterior aspect of the testis, tender and swollen mass. Severe cases such as this patient it can also present with localized redness, dysuria, and systemic symptoms such as fevers and rigor. Physical exam will show intact cremasteric reflex, which help differentiate acute epidermitis from testicular torsion. The underlying cause is mostly chlamydia or Neisseria in men under 35 years, whereas E. coli and Pseudomonas are most common in older men and men having unprotected anal sex. Evaluation should include urine amplification, nucleic acid amplification test for chlamydia and gonorrhea, as well as urinalysis and urine culture treatment. Is ceftriaxone to cover gonorrhea and doxycycline acetomastin for chlamydia infection. Levofloxacin of TMPSMS are recommended agent for patients at low risk for STI. So I guess the older ones. Symptomatic management includes scrotal elevation, application of ice, and NSAID. It's not ultrasound of the scrotum may also be used to aid in diagnosis of epidermitis. Doppler ultrasound of the affected testis will show increased blood flow to the epididymis. However, acute epididymis is clinically diagnosis. Delaying treatment with antibiotics to pursue further imaging will increase the likelihood of complications associated with the infection. If the leading diagnosis were testicular torsion, ultrasound would be the next step. Okay, next.
which of the following is the most accurate conclusion based on this patient's finding? A randomized double-blind trial is performed to assess the efficacy of a new drug for the treatment of strep pharyngitis. A total 590 women between the age of 20 and 34. 590 women aged 20 to 34 have culture modified strep pharyngitis enrolled. 295 received penicillin V, 295 received new drug. Results of the bacteria eradication is 94.2%. and is the group treated with penicillin is 99.4%. In the group treated with new drug, p value 0.04. Which of the following is the most accurate conclusion?
I don't know. Between A and D, study has good internal validity. Yeah,
P
just
value
have
is
it over.
normal. Sorry, p value is statistically significant 0.04,
Yeah.
and new
Goals
drug shows 99.4%. Okay,
internal validity. It is it's D. The study has good internal validity. Randomized controlled trial is a type of prospective study where patients are randomly assigned to receive particular intervention. The intervention may be compared against placebo therapy or against a standard therapy. RCTs form the gold standard of, that. For any study to be valid, regardless of design, internal and external validity must be considered. Internal validity describes the degree to which a study establishes or supports a faithful conclusion about cause and effect, whether the design of the study was sufficient to support the conclusion drawn. Yeah. Sufficient internal validity should limit the degree to which alternative explanation of cause and effects can be reasonable. Internal validity thus refers to whether the exposure, treatment, or variable being tested makes a difference, and whether the experiment was designed in a way to support the claim. External validity determines whether an experiment can be generalized and its conclusions apply to groups beyond the considered study population. In this example, the sample comprises a specific demographic group, young women with strep pharyngitis. The restricted age of demographic characteristics decreases the likelihood of confounding variables. The external validity is decreased compared to internal validity for this study. It's now A, the new drug should be gold standard for treatment of strep pharyngitis. It's a premature conclusion. This study lacks external validity or generalizability. Additionally, the findings of the study should be replicated before being translated into routine clinical. Okay, makes sense. Okay, next. Wait, oh, it's this one.
to tell you diagnosis.
Oh my God. Uh, no. Squamous?
Why? Because there is an ulcer,
No. Uh,
non-healing
I
ulcer,
just,
maybe squamous.
maybe I don't know. I just guessed. You told me to guess, so I just guessed.
No,
Okay.
in like in basal cell, there should be a telangiectasia, but there is no telangiectasia. And then the next thing you need to look, there are three cancer, like either melanoma, either basal cell carcinoma or squamous cell carcinoma. Squamous cell carcinoma comes with, like, what can I say? Squamous cell carcinoma comes with non-healing ulcer or burn history, this type of thing. And if you found any telangiectasia, like dilated blood vessel, that is basal cell carcinoma, usually. Okay, you want me to read the option?
Mm-hmm.
Sorry, a 64-year-old woman comes to the office for a non-healing lesion of the lower leg. She reports that the lesion does not itch, bleed, or drain. She has not attempted any treatment or remedies. She does not wear any clothing or other items that rub the affected area. Vital signs are within normal limit. Examination of the lower extremity discloses the findings of the photograph. The remainder of the examination shows no abnormality. Which of the following is the most likely diagnosis? Okay.
Okay. So it is squamous. SCC is the second most common form of skin cancer following BCC. SCC of the skin related to chronic UV damage, which triggers development of dimers and mutation in P53 tumor suppressant. Additional risk factors involve development of SCC include iatrogenic immunosuppression, especially solid organ transplant, genetic disease, albinism, scleroderma pigmentosa. XCC classically presents as a rough papule or nodule with erosion or ulceration, on overlying hyperkeratotic scale. Pathology discloses parakeratosis, loss of epidermal, whatever, keratin pearls, full thickness epidermia, atypia, and invasion of the dermis. Unlike basal cell carcinoma, SCC carries a high risk for metastasis, especially in lesions with neurovascular involvement. Lesions consistent with ACC1 and skin biopsy and are treated with excision-based therapies, including the Mohs surgery and electrodesiccation and curetas. This patient chronic eroded scaly lesion on sun-exposed skin is suggestive of ACC. It's not BCC, most common subtype of cancer, and is associated with UV exposure too, like actinic keratosis. BCC presents as pearly papule with rolled borders and overlying telangiectasia and may have focal erosion or ulceration. BCC is locally invasive, however, no metastasis. Lesions consistent with BCC warrant skin biopsy for further evaluation. Treatment of BCC includes electrodesiccation, curettage, excision, topical imiquimod therapy. While BCC are commonly found in South exposed area on elderly individuals, they do not present with significant overlying scale. I think that's it.
Next,
Mhm.
picture is not clear. Okay, let's see. A 4 month old, a 4 month old breastfed female, sorry, a 4 month old breastfed male infant is brought to the clinic by his parent for a well child examination. The birth weight is 3.5 kg and his current weight is 7,000. His current weight is 7,000 gram, like 7 kg. The patient asks if there is child's weight gain is appropriate. The patient's growth and development are as shown in the growth chart. Vital signs are within normal limit. The physical examination shows no abnormality. Which of the following is the most appropriate statement to the patient about their patient's weight at this time?
I cannot see the
Yes,
question.
you can't guess without seeing that thing.
Hmm.
I think that give a random answer.
Yeah, I cannot
Don't
see the.
waste our time on this. Okay, let's see.
Okay, it's his waking is appropriate.
I am right.
Grow rates are useful way of assessing child's growth over a given interval of time and can detect abnormal growth rate pattern that may indicate medical condition. There are several frequently employed growth charts, including the chart shown, which was the whatever. Percentiles are also plotted for length and weight at a particular age. In this scenario, the patient was born at 7 pounds, which falls near the 50 percentile for birth weight. At age 4 months, he weighs like 15 pounds, which falls near the 65 percentile for weight for his age. The parent should be assured that the gain weight is appropriate. Children at extreme ends of the growth curve are often healthy. However, persistent accelerated or decelerated growth rates usually warrant further investigation. Common cause of accelerated weight gain include endocrine abnormalities or genetic abnormalities, mm, while decelerated weight gain may occur because of malnutrition, immunodeficiency, systemic abnormalities. Accelerated length may occur as a result of metabolic or genetic abnormalities like Marfan or Klinefelter, homocystinuria, excess growth hormone. And decelerated length may occur because of growth hormone deficiency, hypothyroidism, anemia. Both height and weight percentile and growth rate should be considered when any abnormality is suspected. It's not E. Where is E?
Why you are
It's,
reading this?
oh, I just because I was well, I couldn't really
Is
see
there
that.
is anything important you have found in this question? Like any take home?
No.
Then skip this question.
Okay. Because I was wondering because this
You
like
will not
I
until
cannot see the
unless you see the picture. You cannot match this picture with your explanation. You, you, do you remember we try to understand one of the question from the world? Like not one, two to three question from the world with this type of question. So you need to
mm,
match with the picture.
mhm.
Okay.
Yeah, that's true.
Okay,
You're not.
56-year-old postmenopausal woman with type 2 diabetes mellitus and hypertension comes to the clinic for a routine follow-up examination. Her parents immigrated from Libya. She says she has been feeling more tired than usual for the past 2 months. She has been sleeping well but becomes fatigued as the day progresses. She otherwise has no symptoms. Vital signs are within normal limit. Physical examination shows no abnormality. Lab shows hemoglobin 10.5, hematocrit 33%, mean corpuscular volume is 75, RDW red cell distribution what is high, ferritin is it low or normal, and
Okay.
TSH is normal.
It's hemoglobin. Because hemoglobin female is low. Hematocrit female are both low. Mean corpuscular, I guess, is low. And then red cell distribution is high.
Is high.
And
Ferritin
ferritin, where is ferritin? Where is ferritin? Where is ferritin? Right here, female 10 to 120, so it's normal. And then, wait, it's a woman, right? Yeah. And then TSH
is
is
normal.
normal. So ferritin is normal, but so iron deficiency cannot be. Mm, cause of depression, it cannot be iron deficiency. Folic acid, no. Colon cancer, probably no. Anemia of chronic disease, blah blah blah. And thalassemia. Red cell distribution is high. Mm. If red cell distribution is high,
Yes,
then it cannot be thalassemia.
can be.
No, no, because thalassemia red cell distribution will be normal. And and it cannot be iron deficiency because ferritin is normal. So it's between colon cancer. But if it's
There is
colon
no
cancer,
weight loss.
yeah, then it's anemia. But it's either way. Colon cancer will give the iron deficiency anemia and be
Why
coming
iron
back.
deficiency anemia? This patient.
Yeah, it's
Why?
not iron deficiency.
Postmenopausal. She is not menopausal. There
Yeah, so
is
it's not.
no way of losing hemoglobin.
Yeah, it's probably chronic disease. Eh, Okay.
What is the chronic disease?
She probably has something. I don't know what she has, but she probably has something.
Okay,
It's either that or thalassemia, but I don't think it's thalassemia. But let's see. It's thalassemia. Never mind. Thalassemia is the most likely diagnosis in postmenopausal patient with mild microcytic anemia and normal ferritin concentration presenting with 2 months of progressive fatigue. Thalassemia is an inherited condition in which one or more alleles of either alpha or beta globin gene is rendered non-functional, thereby interfering with normal synthesis of hemoglobin A. Normal adult hemoglobin consists of two alpha and two beta subunits, which together form two alpha, two beta hemoglobin A. And unique conformation that has high affinity for oxygen in the lungs and can offload oxygen directly into the peripheral tissues. Patients who have one or more deficient B globin genes, beta thalassemia major or minor, the normal hemoglobin A molecule cannot be effectively assembled, and the excess alpha globin chains combine with one another to form insoluble tetramer. There are four alpha globin alleles, and the severity of alpha thalassemia depends upon the number of these alleles that are non-functional. Many patients with alpha thalassemia trait are asymptomatic and only exhibit minimal decrease in hemoglobin concentration, although microcytosis is frequently encountered. Patients with more non-functional alleles present with increasingly severe levels of anemia. Microcytosis and the presence of target cells on peripheral blood smear are characteristic of both alpha and beta thalassemia. These two conditions can be reliable, reliably distinguished using hemoglobin electrophoresis. Patients with thalassemia trait, thalassemia minor are often incorrectly diagnosed as having iron deficiency anemia. And in these instances, oral iron therapy will have no effect on the hemoglobin concentration. This patient normal ferritin concentration helps exclude iron deficiency. It's not anemia of chronic disease. It's a common finding in autoimmune and inflammatory disease. Chronic infection is malignancy. Increased hepcidin concentration lessens iron absorption and increases iron storage in the endothelial system, which prevent the use of iron by erythrocyte precursors, thereby resulting in anemia. This will present with increase rather than decreased ferritin. Oh, okay. Things will be increased. Sorry. Okay. Think we are done for today because it's 11. Um, we can continue tomorrow. Good. Hello?
yes,
Oh, yeah, I said that it's 11, so we can stop for today if you want to.
we can do one question.
Okay. Got it.
We can do up to 20.
Okay.
A 50-year-old woman comes to the physician because of 3-day history of swelling, redness, and aching pain. A, uh, a 50-year-old woman comes to the physician because of 3-day history of swelling, redness, and aching pain from her right foot to just above her knee. There is no history of trauma. She has a 10-year history of um, hypertension and 3-year history of diabetes mellitus. These medications are metformin, ibuprofen. She works as a bus driver, temperature is 37 from 3 degrees Celsius pulse, 88 per minute respiration, 12 per minute blood pressure, 148 by 92 examination, shows an edema, erythromatous tender right knee. The remainder of the examination showed which of the following is the next step in the diagnosis.
Ready?
Yes,
Okay. So it is Doppler ultrasound of the chest, of the right lower extremity. This DVT, characterized by presence of blood clot within the vein of the upper or lower extremity, and is common issue in patients who spend prolonged time sitting, such as bus driver. Formation of DVT is promoted by features of gout triad: venous stasis, immobility, venous occlusion, endothelial injury like infection, trauma, or inflammation, and hypercoagulability like malignancy, genetic or acquired thrombophilia. Patient with history of consistent immobility and unilateral extremity swelling should undergo duplex ultrasound of the extremity to evaluate for DVT. There are both modified and non-modified risk factors associated with venous thromboembolic disease. Modifiable actions to reduce the incidence of DVT is minimizing immobility, especially in prothrombotic postoperative state, avoiding hormonal birth control, smoking cessation, weight loss, and if immobilized, using a prophylactic anticoagulant such as low dose subcutaneous heparin. Non-modifiable risk factors include age, history of genetic or acquired hypercoagulability, family history, pregnancy. Complications of DVT include embolus to the lung, oh, Primacia cerulean or alba dolens, and thrombotic syndrome. Treatment includes anticoagulation, placement of IVC or thrombolysis or thrombectomy. It is not spiral CT of the chest, appropriate when there is concern of PE. This patient will generally have tachycardia, shortness of breath, chest discomfort, fevers. Well scores can be used to help guide workup and treatment. This patient does not show PE. Okay, okay,
You can stop.
okay. See you tomorrow.